Are you able to see the slides?
Yes, sir.
Yes, sir.
Yes, sir.
So this is the first ask you question. You are seeing some picture here. What is shown here?
High flow nasal
nasal
oxygen.
oxygen.
Flow nasal oxygen cannula. Very good. What are its advantages?
Patient will be, sir, it will provide fixed FiO2, sir. Patient will be more comfortable than the face mask. So there will be less interruptions. The patient can communicate, patient can eat even with the cannula, sir.
That is all with the regular cannula, low flow oxygen cannula also, these advantages are there. Ask you when you write an answer, it will be more specific for the particular equipment that they are showing. So what is this here?
Humidifier.
Humidification, sir.
This is heated circuit. So warmed and humidified gases are delivered. So high flow washes out the carbon dioxide in anatomical dead space, delivers fairly constant FiO2, warmed and humidified gas reduce energy expenditure, decreased resistance to breathing is there. These are the 4 advantages of nasal high flow nasal cannula. Washes out the CO2 in the anatomical dead space, delivers a fairly constant FiO2, warmed and humidified oxygen, and decreased airway resistance. What are the contraindications for its use?
Patient with poor respiratory.
Respiratory effort, spontaneous breathing. Okay. That is general. Anybody with a poor respiratory effort, spontaneous the supplementation is not going to help. Altered sensorium, facial injury, excessive secretions, hemodynamic instability, or airway obstruction. So these are all the conditions where they should not be used. What is the maximum flow possible?
60 liters.
Excellent. 60 liters per minute. How much is FiO2? How much of FiO2 can be delivered?
1.
Nearly 95%.
99%.
What is shown here and where are they used? Irrigation fluid. You see 2 bottles. Are they both same?
No,
Please
sir.
take time to read
One is
them.
glycine and another one is.
The other one is 1.5% glycine.
First, you must describe what you are seeing. You are seeing how many liters bottle this is?
5,000.
Able to
5
see
liters.
the 5 liters supporter there? Shown here are 3 liter plastic bottles of saline and 1.5% glycine. Both are only 3 liters, 3000 ml bottle. Okay?
Yes, sir.
So that is what is shown here. That is the first part of the answer. Where are they used? That is the second part.
TURP.
Copy.
Which one? Both are used in TRP or only one?
Both can use, sir.
Can be used in TURP.
But commonly, which one they use?
NS, sir.
9% NaCl.
TRP they use NS. Which hospital?
Not, sir.
Not.
Sir, in SIMS
don't
also they
use
use NS only, sir.
Huh?
In SIMS also they are using NS only.
Oh, I see. No glycine.
No,
No.
sir.
Okay. 1.5 glycine is preferred for TRP. Normal saline irrigation used for surgeries, arthroscopic surgeries and wound irrigation. So my urologists, they all prefer only glycine. What are the advantages and disadvantages of using glycine in the case?
So it is non-conductive and non-hemolytic.
Okay.
And
Advantage.
Glycine is
Advantage.
neuro.
Be metabolized.
So it will it will produce toxicity.
You must remember that in the OSCE, you will have 4-5 questions for each slide. So you have to quickly think and write, and the time given is very short. And each question you have to answer in a separate answer sheet. and they will take away the sheet immediately after the time is over. So you cannot keep it for long and think slowly. So you must develop the habit of thinking fast and answering fast. So the advantages of glycine are it is a naturally available amino acid, cost is low, current dispersal is good, and vision is good for the surgeon. Disadvantages, it is an inhibitory transmitter, so it may cause cerebral depression. It's hypoosmolar compared to normal saline. So can get absorbed through the venous channel, and transient loss of vision is one of the postoperative complications. What do you see here?
Urethroskop.
Something
Gla-
flashing,
glaze.
some fluorescent light like thing you are seeing.
Yes, sir.
Laser.
Yeah, very good. It is a
Filmy,
Holmium
Holmy
laser
laser
enucleation of
enucleation.
prostate. Okay, so this is how the picture will look like. It's another laser enucleation of prostate. There are two pictures shown here. What are they?
Subclavian artery and subclavian veins.
Which one? Both are subclavian artery and subclavian vein. On the left, left is an ultrasound picture. The right one is a ultrasound probe position with a needle insertion.
The large one will be veins.
Which vein?
Subclavian veins, sir.
Subclavian vein is so huge.
So that
the
looks
first
like
one
internal
is
jugular.
ultrasound image of internal jugular vein and the carotid artery. Okay. The second one is ultrasound imaging done with the probe of subclavian vein in transverse and longitudinal axis. Okay. So these are the two pictures. What are the landmarks for IJV cannulation in the absence of ultrasound?
Two heads of
Between the two heads of
One at a
sternocleidomastoid.
time. One at a time.
A triangle formed by the two heads of sternocleidomastoid. The apex of the triangle will be the landmark.
Clavicle.
So right IJV is the preferred option always. Turn the head to the left side. Apex of the triangle formed by the two heads of sternocleidomastoid muscle. Needle inserted at an angle of 20 to 30 degrees twisting, directing towards the ipsilateral nipple. Okay? What are the indications, advantages, and disadvantages of subclavian vein cannulation?
Indications: patients with having with neck burns, neck contracture, and surgery in the neck. For nutrition.
So it's a long-term use for TPN or chemo. Even if you write one, it is more than enough. This is a more common indication. Long-term use is you prefer subclavian rather than jugular. Advantage: patient comfort is more free neck movements. Disadvantages: bleeding during insertion cannot be controlled easily. More chances of pneumothorax. Okay? So these are all the things. What is shown here? Mention the conditions.
It's a
Patterns of thromboelastosis.
elastogram.
Thromboelastographic tracings. What are the conditions which cause all these things from the top to bottom?
First one is normal.
One is normal, very good. Second one,
Second one, initiation of clotting is prolonged, sir.
prolonged, very good. So patient may be on anticoagulants.
Anticoagulant deficiency.
Third one,
Maximum clot formation is less.
okay. Fourth one,
Early fibrinolysis.
early fibrinolysis. Fifth one,
Hypercoagulation.
hypercoagulation. Sixth,
Decreased fibrinolysis. Abnormal fibrinolysis.
Now, initially, this looks quite big enough, then it tapers down. Instead of maintaining the same width, it's going down. That means initially the clotting is good, then it decreases. In which condition it will happen?
DIC.
DAC, yes, disseminated intravascular. Last one,
Both.
hypocoagulation. Okay.
Yes, sir.
So various types of clot formation using TEG. So first one is normal, second one is anticoagulation, like factor deficiency. That is reaction time is prolonged, MA angle decrease. Then this is happening in platelet blockers, thrombocytopenia, and here this poor fibrinolysis is taking place. Initial clot formation tapers down. This is hypercoagulation because of the width and the maintaining. This is DAC stage 1 where hypercoagulable state with the secondary fibrinolysis, and in stage 2 of DAC it becomes hypocoagulable. So it becomes a long linear graph. What are the points of care testing done to assess coagulation?
So activated clotting time, thromboelastogram, ROTEM.
Very good. So GT, ACT, TEG, ROTEM are the points of care testing. How TEG differs from ROTEM?
Sir, be static and only the cup will be rotating, sir. In ROTEM, both the pin and the cup will be rotating.
Then how will it form? Only one thing has to rotate. So the TEG cup rotates, the ROTEM pin rotates. Okay, so this is the picture you can remember. You can see thromboelastography, the cup is rotating. The arrows are showing here, the pin is static. Whereas in ROTEM, the pin is rotating, oscillating pin. The cup is static. Okay, then you get this type of graph. What is the definition of supraventricular tachycardia?
So it is a narrow complex tachycardia.
With heart rate of more than 100 per minute.
Regular
With
rhythm.
normal QR,
Regular
with the
Word
P
itself
wave
is
followed by a QRS complex.
The
The
terminology
P wave
itself
and the
is-
T wave coincide with one another, sir.
Huh?
The P wave and the T waves will coincide with one another.
The term supraventricular tachycardia refers to any tachydysrhythmia arising from above the level of the ventricle or bundle of his. It encompasses regular atrial, irregular atrial, and regular atrioventricular tachycardia. Okay, so that is the definition of supraventricular tachycardia. What is seen in this EKG?
atrial flutter.
Will flutter or fibrillation?
Fibrillation with irregular.
And OP.
How do you diagnose AF clinically?
Is
Very good, by bulk deficit. What are the goals in treatment of AF?
Hemodynamic stability.
To prevent cardioembolic events
Control the
from
rate.
rhythm control and anticoagulation.
Rate control, rhythm control, and anticoagulation. What is the difference between cardioversion and defibrillation?
Cardioversion, which is synchronized, where defibrillation, which is asynchronized current.
It's done with lesser energy, 50 to 150 joules is cardioversion. Of course, it can be synchronized also. Defib uses a higher energy, 200 to 350 joules. The CV is to revert atrial arrhythmias and defib is to revert ventricular arrhythmias. What is shown here and what do the two angles shown represent?
Capnography, which is alpha angle and beta angles.
What do they represent? The question is, what do the two angles represent? I'm not asking what is the name of the angles. That is given already there. So the first answer is a normal capnograph trace. The second part of the question, what does the alpha angle represent and what does the beta angle represent?
Alpha represents the dead space, etc.
Ah,
Okay.
very good.
And beta represents
Maximum end-tidal carbon dioxide.
tidal concentration.
If it is
Which includes the dead space and the alveolar CO2.
alpha angle indicates change from dead space gas to alveolar gas, and if it is more than 90 degrees, indicates bronchospasm or VQ mismatch. Okay. Beta angle indicates EtCO2, and if more than 90, indicates rebreathing or mechanical obstruction. These are the indications of that. Identify the conditions based on the capnographic tracings given below.
First one is bronchospasm. Any obstruction,
Obstruction.
expiratory flow, sir.
Second,
Cardiac
cardiac oscillations. Very good. Third,
spontaneous effort, curare cleft.
curare cleft. Very good. Airflow obstruction, cardiac oscillations, and curare cleft.
Expiratory valve abnormality, sir. Expiratory valve malfunctioning, expiratory valve leak, rebreathing.
Third one, is this rebreathing? What do you mean?
Last one is normal.
Hypoventilation, sir.
Which one? This one or this one? Start
The
from the
middle
left
one.
and go. Left one, middle, and then right. What is this?
This expiratory valve malfunction.
Malfunctioning. Okay, this is
Hyperventilation or leak, sir.
Hypovolemia.
Let us see. Leak in the sampling tube, hypocapnia, normal tracing. Okay. What is this?
Inspiratory valve.
Which one? This one, expiratory valve problem?
Inspiratory valve.
Expiratory valve problem. Okay. Both are wrong. And what about this?
Deficient soda lime, sir.
Rebreathing or
Rebreathing.
exertions.
So here it is single lung transplant. Okay. So this is the capnography you will get in a single lung transplant. This is the rebreathing of CO2. So it is not touching the baseline. What is shown here?
Off. Faster.
Yes, it's a cardiopulmonary bypass machine. What are the components of this machine?
Cannulae, oxygenator, humidifier.
Humidifier.
Sorry, sir. Reservoir, oxygenator, and the various PVC tubing, the centrifugal and or the roller pumps.
Cardiotomy system.
Yes, sir.
Venous arterial cannulae, reservoir, oxygenator, pumps, heat exchanger, tubing, cardiotomy circuits. So these are all the components of that. And see, this is the picture to remember that the venous drainage is from the left, right heart, right atrium, IVC or HVC to the reservoir. This pump to roller pump to the oxygenator, air heat exchanger and gases, anything if you want to add, you can add it there. Then it is gas blender, everything is given here. Then once it is oxygenated, it is pumped back into the aorta beyond the cross band. And that is good. What are the types of pumps used for pushing the blood? These are the pumps. See, these are the pumps
pumps
which
and
are
roller pumps.
roller pump and centrifugal pump. Okay. What are the types of oxygenators used? Membrane and bubble oxygenators. Okay. What is the difference between pulsatile and non-pulsatile flow? Pulsatile flow mimics normal blood flow in human blood vessels and a pulse pressure of 10 to 15 millimeters. Non-pulsatile flow is a continuous flow with lesser pulse pressure and shear force. So that is the difference. Normally, pulsatile flow will mimic normal blood flow, so more peripheral feeding will be much better. Tissue perfusion will be better in pulsatile flow, but shear force is more. What is shown here?
Sir, the
Scavenging.
Scavenging.
leak test, sir.
But he is holding something in the hand. Like,
It's a negative
leaky
leak
pulse.
test, sir.
Huh?
Negative leak test.
Universal leak test. Yes, it's called universal leak test or negative pressure leak test. How is it done?
So we have to collapse the cuff and then we have to connect it to the outlet. If it is auto filling or if it is getting filled, then there is a leak. So
Very good. But timing everything. Switch the machine to off position. Keep the flow meter and vaporizers in off position. Attach a suction bulb with a rubber tube and adapter to common gas outlet. Squeeze the suction bulb a few times to collapse it. The bulb should remain collapsed for at least 10 seconds. Then that means it's a negative leak test. There is no leak at all. If the bulb re-inflates within 10 seconds, there is a leak inside the machine. A 26-year-old lady with a history of fall from a two-wheeler and sustaining injury to her right leg brought to A&E crying in pain. Her ABG shows the following values. pH is 7.56, PCO2 is 31, CO2 120, bicarb is 25 milliequivalents. What is your interpretation of the ABG?
sir, hyperventilation because of pains, respiratory alkalosis.
Acute respiratory alkalosis. That is the answer. What is your interpretation, Naga? You don't have to explain the cause of all these things. You have to say whether it is acute or chronic, whether it is respiratory acidosis or alkalosis. So whether it is respiratory or metabolic. These are the three things that you mention in your interpretation answer. So this is an acute respiratory alkalosis. What is the cause of this change?
Hyperventilation because of
Patient pain causing hyperventilation. How to correct this?
Ask the patient to breathe into a breathing bag, sir.
we have to control the
Analgesics.
pain and you have to reassure the patient.
Analgesic immobilization of the injured limb. Once the pain comes down, the patient will automatically stop hyperventilating and blood gas will return to normal. Okay, so it is the treatment of the primary cause, the injury and the pain. What are the effects of respiratory alkalosis if it is prolonged?
Cerebral hypoperfusion and loss of
The conscious patient, what will they feel if they are hyperventilating and going for respiratory alkalosis?
they'll be dyspneic and
Fatigability.
Lightheadedness, syncope, confusion, paresthesia, cramps, carpopedal spasm. Okay, all these things will happen. How is respiratory alkalosis useful in anesthesia?
Induction will be faster, sir.
Induction will be faster.
so it reduces ICP in case of neuro anesthesia.
Very good. Temporary hyperventilation and alkalosis will reduce ICP. Okay, then actually temporary hyperventilation helps to delay recovery from neuromuscular block syndrome. So if you are using a non-depolarizing muscle relaxant and the surgeon is almost towards the end of the closure and the patient starts breathing and you don't want to repeat the relaxant, so simply hyperventilate and wash out the carbon dioxide, which will take away the stimulation for respiration and you can prolong the neuromuscular blocking effect for some more minutes, 2 minutes at least, without giving a relaxant. Similarly, in pregnant patients, mild respiratory alkalosis should be maintained if you are giving GA for any surgery in a pregnant woman, because normally they have a mild respiratory alkalosis during pregnancy. So the same should be maintained here. What is shown here?
Emlacrin eutatic mixture of local anesthesias.
Very good. It is a synthetic mixture of two local anesthetic drugs, lignocaine and prilocaine in equal volume. What is an eutatic mixture? What is the definition of an eutatic mixture?
Equal proportions.
When two drugs with different melting points are mixed in equal proportion, they attain a new melting point and remain in a semi-solid state. That is what is called the eutatic mixture. Two drugs, if individually, if you see lignocaine has a different melting point and prilocaine has a different melting point. But when you mix them both, it attains a new melting point where they will remain as a semi-solid cream instead of becoming liquid. That is the advantage of mixing them. Why does it require an occlusive dressing and how does it act? What is the mechanism of its action?
Occlusive dressing to have more contact time with the
Very good.
skin.
It is needed for remain in contact. It acts on the sensory nerve endings under the skin. Okay. What complication can occur and why if applied to raw area? It should be applied only to intact skin. You should not apply it on the raw areas.
Skin irritation.
Irritation. Local anesthetic will cause irritation. It is going to cause numbness and anesthesia there. Loss of sensation. How can cause irritation? What can prilocaine produce if it gets absorbed into the body?
Neurotox. Methylene.
Hemoglobinemia can occur due to absorption of prilocaine, which is metabolized to para-aminobenzoic acid or PABA. Okay? That is the reason why it should not be applied to raw areas. How do you treat methemoglobinemia? By mistake, if somebody has applied
Will give methylene blue was
Antidote as methylene
IV
blue.
methylene blue 1 milligram per kg. Always you must mention the dose also in the exam. IV methylene blue 1 milligram per kg over 5 minutes or ascorbic acid 500 milligram IV. What are the uses of emlacrin?
Sir, for IV cannulation, for
Used
ear
in
piercing,
pediatric patients before venipuncture or even circumcision is done under emlacrin application. In adults, for cosmetic procedures like VAT, tattoo removal or harvesting small skin graft, you can use this. Describe the findings in the X-ray shown.
sir, left-sided pneumothorax with passive lung collapse.
So this is an X-ray chest PA view. Always the description first you must start whether it is a X-ray chest APV or PA view. No bronchovascular markings are seen on the left side. Deviation of tracheal air shadow to the right. Dark airspace in the entire left hemithorax with a collapsed lung. So it is a left-sided tension pneumothorax. Okay, because the mediastinum is also pushed and the trachea is pushed. So that is a, if it is a non-tension pneumothorax, it will not have pushed all these structures. What are the causes of pneumothorax, not tension pneumothorax? Any pneumothorax, what are the causes?
Sir, spontaneous pneumothorax in case of bullous.
It can be classified into spontaneous and acquired. Spontaneous again can be classified into primary and secondary. Primary can be because of subpleural blood rupture or bullous rupture. Secondary can occur in COPD, tuberculosis, necrotizing pneumonia, malignancy, interstitial lung disease, and cystic fibrosis. Acquired conditions, it can be traumatic or iatrogenic. Traumatic, blunt injury, penetrating injury, or barotrauma. Iatrogenic, during central venous cannulation, pleural biopsy, bronchial biopsy, transthoracic needle aspiration biopsy, for some cases, mechanical ventilation. How to evaluate and treat pneumothorax?
Sir, clinically, the patient will have breathing difficulty, decrease in saturation, increase in respiratory rate. On auscultation, there will be reduced air entry. On percussion, the lung will be hyper-resonant.
Treatment is needle thoracotomy, sir, as an emergency management.
Emergency needle thoracotomy.
Later, we can put an ICD.
So this is a primary spontaneous pneumothorax. See whether the patient has dyspnea or a pneumothorax size of more than 2 centimeter on chest radiograph. If these are negative, consider discharge, because that pneumothorax is very, very small. It is not going to cause any problem. Sometimes, when you give a brachial plexus block, you can produce a small pneumothorax. That will be apparent only after you take an X-ray after 10 hours or 12 hours. Until then, it may not be even causing any problem. So unless patient has dyspnea or a pneumothorax of more than 2 centimeters size in the chest radiograph, ignore it. If thinks a patient is dyspneic and the pneumothorax in chest X-ray is more, you can try needle aspiration. And if it is effective, you can just discharge the patient again. If it is ineffective, insert chest drain through intercostal space. If it is failed, refer to specialist for using low pressure suction. If it is successful, remove chest drain after 24 hours, then the full expansion of lung has stopped and the air leak is also stopped. So this is the way to go for. This is the flow diagram you have to remember. What is safe triangle and its boundaries?
Sir, it is in the fourth intercostal space in the midclavicular line. Medially, the lateral border of sir, laterally it is the medial border of latissimus dorsi and
Safe triangle is the safe site for ICD insertion. Okay, and it's bound on by lateral borders of pec major and LD muscles and superiorly by the axilla. ICD tube is to be inserted through the fifth intercostal space in this triangle, not fourth, fifth intercostal space.
okay.
Okay, so that is all about the ICD. A few questions for you to stimulate your thoughts. Okay.